Hello, my name is David Back from the University of Liverpool, and in this talk we're going to focus our attention specifically on drug metabolism and excretion as we look at basic principles of drug disposition and apply it to hepatitis and the direct-acting antivirals. So our learning objectives are to focus on the two major pathways of drug clearance, that is the hepatic clearance and renal clearance mechanisms, and then to understand the major pathways of drug metabolism in the liver, and to describe the role that renal excretion can play in drug disposition. So if we look overall at the clearance of a drug from the body, there are two principal ways. One is through the liver, hepatic clearance, and the other is through the kidney, renal clearance. And we can subdivide hepatic clearance into the mechanisms of metabolism and transport, which can both influence the clearance of the drug, and in the kidney, the mechanisms of filtration through the glomerulus and active transport across particularly the proximal tubule. And if we want to put this into a generalized equation, it is that the total clearance of the drug from the body will be a composite of hepatic clearance plus renal clearance. So in more detail, focusing on the liver, hepatic clearance can be then subdivided into the processes of metabolism and transport. Metabolism is phase 1 metabolism and also phase 2 metabolism. What do we mean by those phases? Well, phase 1 is by the enzymes such as cytochrome P450. Phase 2 is by enzymes such as UGT, which is glucuronidtransferase or sulfotransferase. In transport, we have to think about the uptake of the drug into the liver and then the output from the liver primarily through the biliary transport mechanism into the gallbladder and then back into the intestine. So these are the mechanisms that we have to focus our attention on. So let's hone in on cytochrome P450. This can get fairly complex, but we need to look at it in two ways. The first way is the proportion of the total enzyme present in the liver. So there are multiple different cytochrome P450s. By far the most abundant is CYP3A, but there are other proteins such as CYP1A2, CYP2A6, CYP2B6, CYP2C8, 2C9 for example, and different drugs have these enzymes as their principal route of metabolism. If you look at the proportion of drugs that are substrates for these cytochrome P450s, then around 50% of the drugs that are on the market, maybe 40 to 50%, are being metabolized by cytochrome P450-3A. So that's the principal enzyme, but it doesn't mean to say that we don't have to consider the other enzymes. We really do have to consider the other enzymes because individual drugs are being metabolized in the liver by these different cytochrome P450s. So just an example, I'm not going to go through this slide, but just for your perusal and just to see some examples of drugs which are metabolized by these different enzymes. An example of CYP1A2, for example, theophylline, the drug for airways disease, for CYP2C19, omeprazole, for CYP2D6, a drug such as venlafaxine, and then CYP3A. There are multiple drugs. These are drugs which are sensitive drugs, so they're strongly, in a sense, metabolized by the cytochrome P450. There are also moderately sensitive drugs, so drugs less sensitive to the cytochrome P450, also metabolized, but maybe not to the same extent or the same rate. So just have a look at this slide. This is just a snapshot from the FDA guidelines for looking at substrates of different enzymes. If we look now at the UGT, the glucuronidtransferase enzymes, again, multiple different enzymes, so it can get quite complicated with UGT1A1 through 3, 8, 10, and then the UGT2B7, 17. Different drugs are substrates for these specific enzymes. So we have to understand that we're not just dealing with one mechanism or one pathway. There are multiple different pathways, and sometimes you have a drug metabolized by a CYP and a UGT, so you've got a combined pathway to consider. Then to go to the transporters. Going into the liver cell, which is the blue on this diagram, and the blue hepatocyte, you've got uptake, and the boxes that are ticked there, OATP 1B1 and 1B3, really important uptake transporters, these little shuttle pumps to get the drug into the hepatocyte. And then we've got, looking into the excretion, the tick boxes there, PGP and BCRP, P-glycoprotein, breast cancer resistant protein, which can push the drug from the hepatocyte into the biliary tree and then out of the liver in that way. So we have multiple different transporters which we have to consider in terms of the way that drugs are taken up and then the way that drugs are taken out of the liver. So again, just giving an overview of some of the examples for these different transporters. Listed are the transporter on the column, headed transporter, P-glycoprotein, BCRP, OATP, down through OAT and MATE1, MATE2 and OCT. And you look at the gene nomenclature as well. If you're interested in the gene nomenclature, that is also something that will be seen in different publications and vehicles of drug information. And some of the substrates there, again, listed on the column under substrates. This is again from the FDA.gov website, which is an important source of really being able to understand all the different substrates for different enzymes and transporters. So let's have a schematic of trying to relate everything into one pretty complex profile. So we've got the hepatocyte and we've got uptake into the liver, but we can also have efflux out of the liver back into the bloodstream. We can have metabolism taking place in the liver. We can have biliary efflux into the biliary tree and occasionally biliary uptake from the biliary tree. So we have all these different processes governed by these proteins. I'm not going to go through the names, but you can see the names here, relate them back to the previous slides. And there are multiple different proteins which are clearly very important for us to think about in the overall picture of how a drug is being handled by the liver. Let's focus in on this, and particularly for hepatologists who are watching this, we understand that bilirubin is important, that a rise in bilirubin can occur under certain conditions. So how is the body getting rid of this breakdown product, which is coming from red blood cells, for example, bilirubin unconjugated, UCB, in the bloodstream, unconjugated bilirubin, which can be attached to albumin. The unconjugated bilirubin is taken up into the liver cell. It's using OATP 1B1 or 1B3, occasionally diffusing, getting into the liver cell. But as you go through this diagram, you can see that there are other processes taking place. So unconjugated bilirubin can become conjugated. And it can become conjugated with glucuronide, the glucuronide molecule. And the process is governed by the enzyme UGT1A1, which is the glucuronide transferase enzyme. And once you've got the BMG, the monoglucuronide or the diglucuronide, then it can be excreted out of the body. So if you've got anything taking place which is going to hinder the uptake into the liver, then your bilirubin levels rise. And that is on the way to getting jaundice, for example, where you get an increase in bilirubin in the bloodstream. So I hope that just illustrates the importance of transport and metabolism, which can govern the extent of a change in bilirubin exposure. So finally, let's turn our attention in this module to renal clearance. Renal clearance is an important process for the elimination of some drugs. Many drugs can be filtered. If they're small molecules, they're filtered in the glomerulus. Other drugs undergo active transport using, again, the transport shuttles, the transport proteins in the proximal tubule. Filtration is only going to involve unbound drug, and drug can be bound to proteins. Protein can't be excreted unless you've got a problem in the glomerulus and you get protein in the urine. But the protein is important in keeping the drug in the bloodstream, so it's unbound drug which will be filtered. And active transport is important for us to consider because you can get competition for active transport, and that can affect the excretion of your drug. So overall, renal excretion through the glomerulus or through the proximal tubule in the diagram that we can see at the top. But large drugs find it problematic. So large drugs such as heparin or those bound to plasma proteins cannot be filtered, and these are poorly excreted by the filtration mechanism. So then in the proximal tubule, we have these transport processes important for us to consider, and we'll look at these in a drug interaction module, will be around OCT or OAT, and then on the urine side, MRP and MATE1, for example, are important for us to consider. One of the endogenous compounds that undergoes excretion and is using to some extent active transport is creatinine. Now, in order to measure glomerular filtration rates, so sometimes we need to know what the glomerular filtration rate, how the kidneys are functioning, we measure creatinine in the plasma. And creatinine is not only filtered, about 10 to 15% of creatinine is being actively transported. And it's being transported with these OCT, for example, and potentially OAT as well. And some drugs can inhibit that process and influence, therefore, the exposure of creatinine. And one example is the HIV drug cobicistat, which can block OCT2, and therefore you get raised creatinine and you get a change in your glomerular filtration rate. So it's important for us to understand the implications for drugs acting in the kidney. So in summary, I hope what we've been able to show is that there are two major pathways of clearance. One is the liver, hepatic, and the other is the kidney, renal. That many drugs do undergo extensive metabolism. That's the way the body is getting rid of the drug. And the principal routes that we've considered are CYP, cytochrome P450, as a major pathway, and UGT, glucuronidtransferase, as a more minor pathway. But although the liver is the major site of drug metabolism, remember that we've also thought previously that some drugs can be metabolized as they're being absorbed in the gut wall, and other drugs can undergo metabolism in different cell types. And we haven't thought about that, but it's also important to recognize that in individual cells you can get metabolic processes occurring, and phosphorylation is one of those processes. So remember that influx and efflux transporters are important for determining drug entry into the cell. And then in renal clearance, we've thought about filtration and active transport. These are important considerations in relation to that process, and also as we consider later renal impairment. And for a more detailed overview of metabolic and renal interactions, which will specifically involve the hepatitis C drugs, the DAAs, I'd refer you to session 7, and then specifically around renal interactions, session 8, and these will be presented by our colleague, Professor David Berger.